Wonderful. Well, we're going to get started on the Crisis Jam today on the 9th of February. Welcome, everybody. Just wanted to give a little shout out to what we're going to be talking about today. Remember, a few weeks ago, we did a day in the life of mobile teams, and that was excellent to really understand what they do on a daily basis. And today we've got the Crisis Receiving Center. This is actually a layout of a Crisis Receiving Center that's being built in Washington State. Wanted to remind you that you are amongst many folks, next slide, who are on this call. Last week, we beat records again with over 400 people on the call and over 2,300 people on our newsletter list. So you're amongst many who are working towards the same mission. Next slide. And as you know, it's really easy to have your colleagues who are not on this call join us. So they can always go to the website. We have an easy Zoom link. If they don't have it, they can sign up for the newsletter. And of course, you can go back through anything that we've presented in the past, talks, slide sets, data, things that you've seen that you want to find out more about. Next slide. Next slide. So last week, Aaron Sullivan from the Correct Crisis Intervention Today in New York City put a great quote in the chat, and it really resonated with a lot of us here on this call. So let me just read it. We have also come to this hallowed spot to remind America of the fierce urgency of now. This is no time to engage in the luxury of cooling off or to take the tranquilizing drug of gradualism. And I think this applies both to what we're doing towards 988 and the changes around crisis response in this country, but it also is very specific to the calls, right? We can't have them on hold. We need to be able to talk with the person who's in need right away. So I think we all feel this pressure now. We're now in the year of 988. So just this quote, thank you, Aaron. It just really resonated with a lot of us from Martin Luther King Jr. Next slide. Sad news in the news this week was that Eleanor Owen passed away. Remember that she lived a long life to 101, thankfully, but she was a fierce advocate for mental health for 70 years. Her son had schizophrenia, and she was actually one of the first people to start NAMI in the state of Washington. So just a really good reminder of one of our best advocates. Next slide. I wanted to point out a couple other things that are in the news this week. There has been a lot around suicide, specifically around Black Americans, and we had Miss USA this in the last week. And a lot of people said things like, "You didn't know. She seemed so happy. She on the outside, she was so beautiful. She's a lawyer. She had everything going for her." But as we know, people suffer internally and they may not be sharing it. That's why it's so important, the work that everybody on this call is doing to make a place where people can call and get support. So just wanted to point that out. Next slide. Also wanted to talk about this recent article, Answering the Call Part 1, that was really important this week. We had a couple people on this call, and I think what was really important about it was just talking about, the avalanche of information now. It's not just the people that we usually think who are talking about crisis. Everybody's starting to talk about it. And I think in this year, we're just going to see an avalanche of articles. So it's great that we have the people on this call who can really talk to this, to your neighbors, to your colleagues, to your legislators. Really important. Next slide. Also, we've got podcasts coming along. What Congress and states need to do to set up 988. This was really good because it really talks to the states that they are the ones who really need to lead some of this work. So really important, and I'm glad that that we're starting to see more and more in the news outside of just the news this group reads. The sort of common things that people are touching on. This was a national journal. Next slide. So I'm excited today to talk to have the featured presenters that we have on today. We have Dr. Robert Williamson. Welcome from Connections Health Solutions. He's the founder there and also the Chief Medical Officer of Arizona. And then we also have Dr. Chuck Browning from who's the Chief Medical Officer at RI International. Welcome to the both of you, and I'm looking forward to hearing your featured presentation today.
Thank you.
Thanks so much, Amy. Hey, Robert. I am so looking forward to doing this interview with you. So we're hoping to be able to capture, all that you've done in terms of innovating and tackling the challenges of doing no wrong door work for crisis receiving centers. And I can brag on your openness and collaboration personally with me and sharing some of the things that you guys do at Connections. So I'd like to start off with kind of going back a little bit to the past and what brought you to Arizona and when was the practice of no wrong door to crisis receiving began?
Well, I came out to Arizona in December of 2007. At the time, the primary crisis center in Maricopa County was the UPC in downtown Phoenix, and it was struggling, to say the least. I think it was having 25 complaints to the Department of Health a week, and there are hundreds of complaints to the Regional Behavioral Health Authority a week. And by that time, I already had a little bit of a history of running crisis receiving centers, and so they asked me to come out and try to improve on the structure of the program and to make it functional for the community. The no wrong door policy, I think, it has evolved over the last 20 years since Chris and I have been doing it, and it evolved from a lot of mistakes that we made. But really, it went down the pathway of just decreasing the barriers to accessing care for our customers. And I think that's the first part of it, was realizing who our customers were. So our customers are clearly our patients, their families, their clinics, first responders, especially the police, the local hospitals and the local ERs. And once you realize who your customer base is and what they really need from you, that's really where I think the evolution of the no wrong door policy came from, which is barriers to accessing care. And there, historically, especially in the acute psychiatric community, there were a lot of unreasonable barriers placed in front of patients, in front of the police, in front of everybody. Bizarre things like someone's blood pressure has to be below a certain number for them to be accepted. As long as they're asymptomatic, their blood pressure is fine with me, we can treat that. Or someone's blood alcohol level needs to be, or accepting a transfer from a hospital. Lots of hospitals say if that person has been in seclusion and restraint in the last 24 hours, they're not ready for transport and they're not going to accept those patients. And it was really just trying to decrease all the unnecessary barriers to accessing care for our customers.
So by definition, give me your 1 or 2 sentence definition. Somebody said, what does no wrong door truly mean?
It means that we develop a receiving center that is able to accept anybody and everybody at any time. And that includes, that part of the population that we deal with that's somewhat scary, that, because of the state that they're in, what their level of, their acuity of their psychiatric symptoms, there's a propensity for violence there, especially when you throw in methamphetamines. And that's really, none of us, in the psychiatric community were ever taught how to deal in a safe manner with an acutely psychiatrically ill patient that was violent. Our techs weren't really trained in it. Our nurses were never trained in it. Our doctors were never trained in it. And it's really just being able to provide services for anyone and everyone and not saying no. Look for a reason to be able to say yes.
Great. One of the things that I always hear, and you've got a favorite quote that Margie shared with me about, as a provider, your role in dealing with medical clearance. That I've always enjoyed and repeated often. But could you talk a little about, so many people say that it's not practical to be able to do what you do at the Crisis Receiving Center in terms of not having people go through an emergency department for medical clearance. Could you talk a little bit about that in detail?
Certainly, and we run into that all over the country when people ask us to come take a look at their crisis services, and when we start describing what we think of as a no wrong door policy. Especially if we're taking someone from the community. The police officers find someone in the community and either convince them to come in as a voluntary patient or decide that they need to be involuntary. Well, the vast majority of those individuals have been living just fine with very minimal resources. And I have a hard time making a medical necessity argument that says every single one of those patients needs to go to a medical ER. Really, though, it's all about controlling your fear. The reason all these barriers to accessing care, like going to an ER, it's really about controlling our fear as psychiatric providers and not going down the pathway to risk-averse practices of medicine. Surprisingly, the police are really good at not bringing us people that are dramatically medically unstable. In this neck of the woods here in Phoenix, in Maricopa County, they actually have a better track record than 911 does, than EMS. EMS has brought us more medically unstable people than the police have. And I think that it's developing the relationship with law enforcement and mobile response teams and anyone that's going to want to utilize those services so that that communication is open and both teams know what the other team is capable of. You know, a crisis receiving center is all, for it to operate appropriately, it is all about the relationships that it forms with the other types of providers in the community. It takes a lot of time and effort to do that and to learn to trust each other.
I love that quote about learning how to handle fear. So that's one of the things that needs to be different for the no wrong door approach to work. Could you talk a little bit about some of the other things, your facility policies that you have, staffing patterns?
Certainly. I think that if you're really going to be a receiving center that is going to attempt to stabilize people as opposed to just evaluate them and recommend where they should go for treatment, if you're going to be treating there and attempting to stabilize them, then you have to think about the design of your facility. You know, everything that we do when we are either designing our own facilities or helping someone else, the entire focus of the design is on the safety of the patient, the safety of the staff, and the safety of the facility itself, because they take a lot of wear and tear. And when we're designing, that's all we're thinking about and thinking about. The next level is clearly staffing. Where people fail here is the staffing, because it takes a lot of training of your staff and the appropriate amount of staff to be able to say, we can take anyone, including that person that scares everyone else. And that's the highest cost that any of these crisis receiving centers have, is staffing. And it's the easiest thing to start to cut if you're getting concerned with, you know, your financial arrangements, what have you. But it's the last thing that you should cut, because you cannot do this safely without the appropriate number of staff on the floor, maintaining safety for those three areas that I was describing. And they have to be trained appropriately. You know, Recovery Innovations actually brought to us their therapeutic options. You know, in the past, we were using CPI and seclusion and restraint. And these were not effective training programs for the staff from the standpoint of what we're asking the staff to do. We're asking them to stand up to patients that literally sometimes frighten the police. When Recovery Innovations introduced us to therapeutic options and we ran with that and then went forward with Safe Clinch, it really changed the culture in our facilities. But again, I think it's the training and that you cannot cut the staff. You cannot skimp on the staff, because that's where your safety is.
You mentioned funding issues related to staffing. Could you talk a little bit about funding required for the approach?
I think there's multiple ways to do it. So like in Dallas, we were a 100% fee-for-service program in the crisis receiving center that we set up. And that worked, it worked well. You know, it's about, again, negotiating with whoever the payer source is going to be, whether it's Medicaid or third-party insurance. Originally, when we came to Arizona, it was block funded completely, which was a different business model for me to kind of learn to deal with. But I think it's it's not just one model. You've got to take a look of what are the financial resources in each specific community, where's the cash flowing, and then you've got to get involved in negotiations and not just accept what they tell you that they're going to do. I think one of the biggest things is that when we go someplace and we say we want to open a crisis receiving center and we start talking about the funding sources, what they're afraid of is that we're just going to add cost to the patient's care, an extra day of cost or an extra 2 days of cost without actually doing something to stabilize the situation. Because that's what historically, that's what they have been presented with, and that's what they've dealt with. And then they eventually say, we're not working with you anymore. You're not bringing anything that's actually really effective for the patient. You're not bringing anything that is cutting the overall cost for the community. And it's convincing them to do that. Even our current REBA right now doesn't understand that we operate these crisis services at a hospital level from the standpoint of we hold ourselves at a regulatory level of ideas of a level 1 hospital. And that is the only way that I can really think to do it if we're going to take this huge volume of very acute patients in a safe manner, both for the staff and for the patients. All of those, just holding ourselves accountable to perform at the highest level, both on the medical side and as well as the other psychiatric sides. I consider them the same, but just for the sake of the discussion.
So how does being able to do this correctly, how does it impact the community in terms of the context of the full crisis system, full behavioral health system? And why is being no wrong door at crisis receiving centers so important within that context?
Well, I see the crisis receiving centers as a safety net for the community as a whole, including the patients, the first responders, and the local hospitals. Because if you look at places that have really functional crisis receiving centers, psychiatric receiving centers, they don't have the psychiatric boarding and ERs that the rest of the communities without these type of psychiatric receiving centers have. They have long waits for somebody to get in, even if they're not dangerous, just for an initial appointment. It is the safety net, and everything else, it becomes kind of, I think Chris says this all the time, it's the center of a spider web. Everything comes in and then everything goes out. It is truly the safety net for the crisis system. If I were to go into, and I have done this, if I go into a community that has really no psychiatric crisis responses, the first thing I would recommend to them is to put their resources into a crisis receiving center as opposed to mobile teams or more psychiatric inpatient beds. That's because you can build an entire fully developed crisis program around a crisis receiving center, in my opinion.
Great. Any other words of wisdom, thoughts about this no wrong door approach, the importance of crisis receiving centers to share?
I'm really happy to see that people are starting to run with this, right? From the standpoint that, and to do it at a much higher level of performance than crisis centers have ever done before. There's a couple of us out there, Recovery Innovations, Connections. I think there's 2 more pretty active companies that are doing this in the same vein. I think all of us need to really push this as one of the models to answering some of the foundational problems in delivering psychiatric care to our communities.
Robert, thank you so much for sharing your time and your knowledge and expertise in this. It was great to see you again.
Thank you, Chuck.
Thank you both. Thanks, Dr. Williamson. Thanks, Dr. Chuck. Lots of good questions in the chat. People are really engaged in this conversation. Let me turn it over to our roundtable to see if we have some reflections from either Sabrina Taylor, Richard, Rochelle, anyone? Sabrina, are you on the line?
Yeah, I'm here. I'm a huge fan of both Dr. Williamson and Margie, so it's always lovely to hear them speak. And everything he said is true. We've been working together, him and the Phoenix Police Department and local law enforcement here for decades. And he's right on the money, and he's super supportive of the police department and what our roles should be. So yes, I second everything he said.
Sounds like you have a very good partnership between their center and your department.
We really do. There's constant lines of communication. And, whenever difficulties come up, because they do, people are people, and hiccups happen. They're incredibly supportive. So, I come with data when I can, and, rumors when I can't. And their answer to me is always, thank you, we'll fix it. And it's the same. They come to me with their challenges, and if it's something within my power to fix, then yes, I will fix it. I think it must be challenging for mental health organizations because I'm representing a police department of 3,000 people. I can't just run out and train them all, to be nicer when talking to staff at their facilities. So there's a certain amount of leeway, I guess, that I beg for, just so that we can do the right thing for the patient. We do, of course, have, internal policies and procedures around professionalism, but, that goes so far. So they are very gracious and forgiving. And we really try, like Dr. Williamson said, to just focus on the barriers and remove the barriers.
The communication that you have, and I think the very core trust across the two groups, knowing that each understands each other, probably makes for an amazing, relationship with the community. And so that's really great. Richard, did you have any comments?
Sure. Thank you for the opportunity. It was a great presentation and discussion of some key issues. I just wanted to highlight one point, which I think has broad relevance, which is the role of provider anxiety and fear. And I think that, and how that at times drives decision-making. And of course, we see that around the issue of suicide, but we also see it, of course, around the issue of violence. We see it around the issue of suicide in terms of, that people being directed to emergency rooms because of clinician discomfort and anxiety, but not feeling confident about being able to manage a suicidal, patient, which in part reflects the inadequacies of our training there. And most people who work on the crisis hotlines have less of that because they're talking with suicidal people all the time. And in fact, there's an international study from Denmark showing that a clinic with people who are working all the time with suicidal people over a period of many years saved more lives, which may say something about the ability to kind of stand that anxiety. But I think that same issue comes up in perhaps even more pointed form when there is a perceived threat of aggressiveness or violence that oftentimes may lead us to overutilize what is perceived as, quote, the safest, end quote, alternative. And this impacts things like, are police needed or not needed on mobile crisis visits, for example? Does the person need to go, can they go to a crisis stabilization, or do they really need to go to a hospital? And when you look at kind of the history of acute psychiatric care over the last 20 years, one of the things that you see, for example, is that there was a time not that long ago where it was thought that seclusion and restraint was absolutely essential in many more situations than it's since been determined to be. And the former SAMHSA administrator, Charlie Curry, when he was mental health commissioner in Pennsylvania, led an initiative that markedly reduced seclusion and restraint in the a state psychiatric system in Pennsylvania. He came to SAMHSA. That became a nationwide effort that was, that was successful in reducing seclusion and restraint. So I think that on many of these key issues, addressing when such fear and anxiety is realistic and when it's not, what are prudent precautions, but when are our fears driving the system, when it should be the patient's needs that are driving, the system. So that was one thing that really stood out for me in the discussion.
Richard, thank you so much. And I know that your perspective on how we feel when we are confronted with these situations resonates with a lot of us. I know it resonates with me.
Yeah.
Rochelle, are you on the call?
Yes, I'm here. How are you?
Oh, wonderful. Oh, great. Any comments or reflections on the discussion today?
Sure. The first thing I want to say is I appreciate the presentation and the querying that occurred in the discussion, because it very nicely moved the discussion through the very important, poignant points that one should consider if you are creating a no wrong door policy around crisis receiving centers. But I wanted to talk a little bit about the ease of flow that this kind of environment creates for you. I know for our last board retreat, we actually visited the Arizona program in Phoenix that RI operates, and so the flagship site. And it was very, very curious for me to see exactly how that works in reality. With police dropping off and with the promise that the police won't be there more than 5 minutes. And I think we actually timed the drop off. We were fortunate to see a drop off with an individual who was really not at all psychiatrically stable, and how the police were able to, in a appropriate way, manage getting the person from the vehicle into the building. And there was a little bit of reticence on his part, mostly because of his own fear and his trust, and how that moved very smoothly into him going into the single point of access. And then what was of particular interest to me as a physician was noting how the staff sort of managed in that safe space, interacting, but also the considerations of the medications that would be necessary in order to deal with any scenario that walked through the door. So to Dr. Williamson's point, that medical clearance often gets more complicated and generalized for all patients. Probably the majority of the people who need services require a routine set of medicines just to psychiatrically calm them down enough to be in a posture where they can get a further evaluation. And so that really is predicated on having very, very skilled and very capable and confident staff. And so the whole staffing point, trained staff, the right staff, the number of staff, appropriately matched staff for this kind of work becomes really, really important. And the model, the Arizona site, actually really showed that very nicely. The other thing I wanted to make a point about that site was because it is serves multiple levels of care. It was very nice to see the ease of flow for the patient who enters one door and literally goes through another door for the next level of care. And if they need more, they go through another door for the next level of care. One of the huge problems we have in behavioral care is transitioning care from one level to the next. And it's just nice to really see an environment that allows a transition to flow so smoothly. We lose so many people because the one hand is not communicating with the other hand, and people suffer in the middle. And so that type of setting and environment works really, really well. But a trained law enforcement person interfacing on the front end is not a bad thing. And involuntarily admitting someone who can't consent is not a bad thing if they're handled appropriately. And so
Thank you.
just wanted to make those comments, but I really appreciate the succinctness of the presentation from Dr. Williamson and Dr. Chuck's facilitation. Thank you.
Thank you so much. Thank you so much, Rochelle. So I just wanted to, the sort of takeaways for me is that it was a great presentation, but I think this idea of staffing with the right people, the right amount of people, and the trainings, and I know a lot of people in the chat are writing about what trainings are best, seems critical. So thank you again, Dr. Williamson, Dr. Chuck. Appreciate you both being here today. Well, we're moving on to one of my favorite things every week, which is the hot seat. Yay. We got the hot seat up. Colleen, are you here? I saw you.
Here. Hi.
Okay. Okay. So you're from the National Action Alliance for Suicide Prevention, and I hope today's team will be able to help you. So it's generally accepted that the decision to utilize 911 was born out of its simplicity. The 3 digits are an easy number to remember. But what about 988? The then FCC commissioner, when this started, Ajit Pai, heard requests for 611 and 211, but believed 988 was a better choice because A, 988 was available, B, 9 indicates emergency, C, the parallelism with 911, or all of the above. As you know, best part about the hot seat is you get the knowledge of over 400 people to help you out. So let's put the poll up. Everybody put in your response. I'm going to put in mine. Oh, no, I can't put in mine because I do know the answer. So we'll have people give us our responses. And of course, you can use this, talk it through, call a friend, all kinds of support. You're not alone. Do we have our responses? Here we go. Oh,
wow.
Overwhelming, all of the above. So if you want to go with that, you can. If you want to talk it through, you think there's something else that they were thinking through, that's great. What do you think?
Yeah, I mean, I'm definitely going to go with the crowd on that one, thinking back to those conversations and early meetings that SAMHSA and others coordinated. It's come a long way, and I'm going to go with D, that it was all of the above.
I love it. Well, drum roll, were you correct? Yes, wonderful, congratulations. Woo!
Thanks, everyone.
Awesome. We've got an incredible streak going, and thankfully they initiated this where we have the audience helping us, because I think you and I would both agree that is critical to making some good answers here on the hot seat. So congratulations everyone, especially Colleen, for being on the hot seat today. And we'll move on to the next topic. All right. Stephanie, I see that you're here. So happy to see you. And is Tanya Miles on as well? Oh, yes, she was, because she talked to me about football at the beginning. So I know she's here. All right. So we want Stephanie did a great interview with Tanya, who's a certified peer support specialist and trauma expert in Louisiana. So Stephanie, tell us a little bit about your interview.
Yeah, so actually I was going to introduce Tanja. I think what really stood out to me in the interview was that people are increasingly aware of how integral peers are to the re-engineering of the crisis system, but there seems to be less discussion on how vital peers are to developing and amending policy. And Tanja, she toggles between those two worlds. Can you talk a little bit about that?
Yes, Stephanie, thank you guys so much. Yeah, I go between actual people and policy every day. One day I could be on my phone or at a coffee shop talking to someone, helping them navigate through recovery. The next day I can be talking to legislation or, community leaders about policies that affect people who are struggling with mental health issues and addiction, particularly when it comes to crisis. And so I believe I have a unique perspective because I'm able to see what's going on, boots on the ground, and then take that information to those who are making those decisions and talk about what I'm seeing that's working and not working. And the fact that they trust me enough to listen, I'm always grateful.
Thank you. Yeah, I think what stood out to me was the fact that you are able to toggle between those, and it's actually really affected Louisiana policy. And it shows, as we look to 988, and a lot of this has to be done on the local level. And I think what you were highlighting is without bringing in people with lived experience. And you said also first responders. You mentioned how you talked to 5,000 law enforcement, right?
Yeah.
And none of them knew. None of them had ever heard of 988. So really engaging on the ground at the local level, different groups, how important that is.
Absolutely, because we have to have both in concert. I mean, we can have all these policies that, we think that are working, but when it translates to getting to the people that need it, it's not happening. And so that's why I'm excited as a peer support specialist to use my lived experience, but also look at the research and the policy and the legislation. And, I'm excited that, we're doing that here in Louisiana. I'm excited that, we opened up the first stabilization center here in Baton Rouge for the state of Louisiana. And now that's adding on. And so there are so many great things that are happening. And so the research that I had been doing years ago, particularly when looking at the Crisis Now model and bringing that to the state of Louisiana has been a game changer. And so I'm just excited. Again, I love policy, but I know policy has to make sure it's in place to provide the resources to the people. Other than that, it's just a piece of paper. It's just
Absolutely.
a sentence that's not happening and not being effective.
Thank you so much, Tanja. Thank you.
Thank you.
And Tanja, I apologize for mispronouncing your name. I'm sorry.
It's okay. No, you're good.
Okay. I love your energy. I can just tell from your energy that you're making a big difference, and we are so appreciative of that. Let's move on to the SAMHSA update. Richard, I know you're here. Can you give us a brief update?
Sure, would be glad to. So yesterday we had the first of two convenings associated with the co-sponsorship agreement that SAMHSA has established with the National Association of State Mental Health Program Directors, who in turn have helped organize a variety of different partners, including many who are on this call today. And yesterday's convening really focused on level setting with a variety of different planning and content partners, but also preparing for a larger convening, which would involve reaching out to 4 key audiences: states, territories, and tribes on the one hand, the behavioral health providers as the second group, the crisis call centers, the lifeline centers as the third group, and 911 public service answering points. And one of the things that you see in front of you was a poll that was, this is one of those fancy tech things where people were able to indicate what words they most associated with the transition to 988. And you can see some of the things that really stand out: access, opportunity, hope, equity, transformation, et cetera. And there were also, for the 4 audiences, there was separate breakout groups that were done. I was pleased to be able to co-facilitate the one focusing on the 911 PSAPs, talking with a range of different partners, including federal partners such as the Office of Emergency Medical Services, and as well as groups like the National Emergency Number Association, and a number of our crisis centers are doing a lot of great work with 911 as part of that. And I was also very pleased to co-facilitate that with David Covington. And so I thought that, I thought it was an immensely important dialogue, and it's important that it was the start of a dialogue and not the end of a dialogue. We know our crisis centers have been interacting with 911 for years, but that this is an opportunity to improve and enhance and strengthen that collaboration on behalf of the American people. So, David, you were on that with me. Anything you'd like to add?
Richard, what I thought was most powerful was this emerging connection with these 911 leaders and beginning to see some of their culture and values coming our direction, especially their focus on speed and how that saves lives the faster we get effective care to folks. So it was a thrill, Richard.
Yep, that was certainly great. And so really grateful for everyone who participated, but particularly to NASHBID and to McKinsey and others who are part of the co-sponsorship agreement who really moved this forward. And there will be a national convening in March, date not set yet, that we will let folks know about so that you can potentially participate in that. So more to come on that. And NASHBID in their report out may want to provide additional information from their perspective about how yesterday's event went. I was not able to be in the session on states because I was on the one in 911 PSAPs, but they may have more to say on that. So that's all for me. One other thing that I should say that, because James Wright was not able to be on, at this point, we got a very strong response from states for the $105 million that was available for states and territories. And we have now gotten, and we are encouraged by a strong response to the Lifeline/Vibrant funding opportunity to increase the strength of the backup centers, the Spanish language centers, and the chat and text centers. So that's it for me.
Richard, always really informative. Thank you so much. Brian, do you have a update from NASHBID?
Yes, thank you. And let me just thank Richard for all the work that he's been doing on a daily basis, but also regarding these convenings and the planning that he's been involved in. Let me talk a little bit about one of the issues that was brought up yesterday, and it's an issue that's brought up on frequently with state calls, and that's the IMD issue, the Institution for Mental Disease. And this goes back to the mid-1960s, when the federal government wanted to make clear that Medicaid federal funds were not to be used for long-term psychiatric care. Basically, state hospitals were supposed to be paid for by states. So a term was developed called Institutions for Mental Disease. Now, why is this important? Well, over the years, the concept of long-term care for IMDs changed so that basically community programs were considered IMDs. So a facility with over 16 beds where the primary reason for that program was either mental health or substance use disorder treatment, then those were determined to be IMDs. So why does this matter? Well, Medicaid will not pay for care in an IMD. So what does this have to do with what we're talking about? Well, it is not clear whether crisis programs, as was described earlier today by Dr. Williamson, if you have over 16 beds in your crisis program, you may be determined as an IMD and then not eligible for Medicaid. Now, this is a major problem across the country because if we can't get payment for crisis beds, then that basically knocks out that service. More people will be going to higher level services and unnecessary care. So what we're really trying to encourage states to do is to work with their Medicaid authority to make it clear that crisis services, the crisis beds and crisis stabilization centers are not IMDs, that is basically a service that is there to keep people in the community and decrease the pressure on institutions, decrease the number of individuals that are going to institutions. We can only get a change here if there are enough states working with their Medicaid authorities, who in turn are then working with CMS to clarify that crisis receiving centers that have beds over 16 are not IMDs. So thank you very much.
Really important point. All right, let's move over to legislation. Oh, did you want to say anything about any of your articles?
Yeah, I
Okay.
did want to highlight our 21 series. There was an article, Funding Opportunities for Expanding Crisis Stabilization Systems and Services. And I know funding is boring, but funding is what's going to make a difference going forward. We have to be able to sustain the funding. And this is a really good article by Kirsten Baronio. So I encourage everybody to read it. Keep it on your night table. Thank you.
Thank you. Thank you. All right, moving on to legislation. Sarah, I know you're here.
Yes, thank you so much. If we could go
Thank
to the
you.
next slide quickly, we'll have a quick update. Nothing new on Build Back Better. It may or may not be dead. We are kind of waiting to see. There's a lot going on in the Senate right now. In this second row for FY22 appropriations, it looks like they're close to passing a 3-week continuing resolution that will keep the government open and funded at FY21 levels through March 11th. That passed out of the House yesterday, and it's going to the Senate now. The current continuing resolution is up on February 18th, but it looks like they are close to finalizing an agreement between House and Senate majority and minority top appropriators for an FY22 omnibus. We saw really strong levels of mental health and substance use funding in both the House and Senate drafts of that bill. They're likely to drop from where they were, but it is looking like it's still going to be an increase over the FY21 levels. Once they find an agreement on a top line number, just especially in the HHS space in both bills, they will likely, as they're drafted, be over that amount. So they'll have to drop it, but hopefully still some strong increases in the mental health and substance use space if they're able to get it over the finish line, which it's looking more and more likely. And then last, the very busy month of February is continuing with hearings. There was a hearing in the Senate Finance Committee yesterday on youth mental health with the Surgeon General. And in particular, while there was a lot of discussion, of course, of youth mental health in schools, there was also a question from Senator Bennett of Colorado talking about mobile crisis and asking about historically low reimbursements in Medicaid for mental health and substance use services. So it's an interesting question. I can drop a link to the clip in the chat. But other than that, we've got another hearing next week in Energy and Commerce Oversight and Investigation Subcommittee, and a second hearing on youth mental health to come in Senate Finance as well.
I don't know, that gives me a lot of hope, your report today. Thank you so much.
Thank you.
Joanna, I skipped over you. Would love to hear from you.
Oh no, you're perfect. Yeah, so I just wanted to highlight, we know the 988 Implementation Act, which we've been really excited about, is going to be introduced at the end of February. And in concert with that, we're going to see a 988 and Crisis Services Task Force under the Congressional Mental Health Caucus, also unveiled that week. So we're looking forward to that. And I know we've been very supportive of that. And I think Eric might be on the line today. So we're looking forward to that.
Wonderful, wonderful. All right, let's move forward. Now I went backwards in the slides. Now we need to go forward, and we will talk with Steph Pasternak. You're here, right?
Yes, I am, Amy.
Wonderful, wonderful. Here we are.
Yes, so on the state legislative front, the only new update in terms of new state implementation bills for 988, just flagging in sort of the orangish color there, Oklahoma has introduced House Bill 4227. Right now, we don't have the text for that. There's just placeholder language. So more to come on that in a future call. And I know there's also been a lot of hearings lately on sort of the pending 988 legislation. Laura Evans with Vibrant, did you want to go over some of that activity?
Sure. Yes. Thanks, Steph. As she mentioned, lots of activity going on in the states. New Jersey Senate Bill 311 was heard in the Senate Health, Human Services, and Senior Citizens Committee. That legislation does have a fee attached. It passed out of committee and is now in the Senate Budget Committee. So great work to all the advocates in that state moving that bill forward. I know that there's been a lot of activity and conversation there. We also saw the Hawaii bills related to 988 implementation move out of the Senate Health Committee there, and they are now in the Senate Ways and Means Committee. There's been some amendments to those bills, so we are also kind of watching those closely. I know Steph is going to talk a little bit about budget bills, but I will kind of also note just New York recently released an RFP for crisis stabilization services, and they do have 35 million or so for crisis centers in their state budget. And of course, that's not official until passed by the legislature. And then Colorado just this week introduced legislation addressing some of the crisis response portion. In Colorado last year passed the 988 enterprise legislation outlining a fee in fortifying the center. So lots of activity stuff. I don't know if you want to address some of the budget issues.
Yeah, I just wanted to quickly mention what we're not really able to capture on the map is also a lot of activity in states, budget bills, appropriations proposals. So just to name a few things, Minnesota's governor is proposing a 12-cent telecommunications fee to support their 988 system. New Mexico has 988 specific funding in their pending budget bill, which is House Bill 2. Missouri's governor is recommending $28.5 million to support 988 in their mobile crisis teams for FY23. Mississippi, their pending COVID spending bill, Senate Bill 2865, has earmarked $3 million for the first year of 988 implementation and $2 million in the years coming after that. And we also know the pending California budget bill has a lot of money set aside for 988 as well. So just a disclaimer that the map isn't fully reflective of all the 988 policy that's upcoming, but we will try to update folks on what else is going on verbally each week as well. So that's the update.
Sounds great. And your map is filling in. So I feel good. It's a sign every week that another state has some color to it. Is very exciting. And some of the states that are still gray, you mentioned today, are moving forward. So that's great news. As the group knows, we are making states stats cards. So we'll move forward with those. We have 4 currently finished. Virginia, let's see, Virginia, which other ones do we have done? We've got Virginia, they were marked on the last sheet. Utah, and these have some details about the legislation and more about the population. Nevada, and we've got 1 more done, and we're going to be working on the 5th and 6th one. So those are coming, collectible, I would say. All right, something I'm really excited about, next slide, is we're introducing a new part to the Crisis Jam, as if we aren't jam-packed enough. I'm really excited about this. This is the Data Corner. We're going to be having a guest speaker probably the 2nd week of every month around data to give us a little bit of information. And I'm welcoming Matthew Goldman, who's leading this effort for us. So welcome, and excited to hear what you've got to share with us today.
Thank you so much, Amy, and it's great to be here. Really excited to be launching Data Corner for the Crisis Jam. So I'm Matt Goldman. I'm a psychiatrist by training, currently the medical director for crisis services for the Department of Public Health in San Francisco, and also on volunteer faculty at UCSF, where I'm a mental health services researcher. So I'm very much in the interface of implementing crisis services, but then also thinking about data evaluation and research to try to expand the evidence base. So if we could go to the next slide, I want to set the frame for what are we talking about Data Corner? Why do we need a Data Corner? One of the main justifications that brought us to this point was an acknowledgement that there are many gaps in crisis research. We're at a time right now where there's so much energy and so much need to implement services, but we're faced by a real challenge, which is that the evidence base hasn't been developed in a lot of areas that are very important for how crisis services are being implemented nationally. So I put together this matrix that helps orient us. And what I did is in the columns here, you see each of the different components of a crisis service. So call centers and text centers, mobile and outreach teams, psych emergency services with stabilization units and residential services, and then post-crisis follow-up and linkage to care. And on the rows here, I've organized this based on domains from the Roadmap to the Ideal Crisis System that was published by the National Council, where the three main areas that need to be developed in crisis services are around accountability and finance, a basic array of capacities and services, and then also clinical best practices, or what I think of sometimes as care pathways. Then we can see that at the intersection of each of these different pieces, there are big questions in red here that we need more information on. So for example, for call centers and text centers, there's not much work that's been done on things like how do these call centers actually impact diversion from 911s, emergency departments, and criminal, legal, and carceral settings? What's the effectiveness of 988 triage protocols, or soon to be 988 triage protocols across different populations? And then also clinical best practices for non-suicidal crisis call triage. Of course, we have a wonderful evidence base for the National Suicide Prevention Lifeline that's been developed by Drs. Gould, Califat, Dr. McKeon, and others, but that's more focused on the suicide hotline piece. When 988 expands to this broader vision of a suicide crisis call line, what are best practices in that kind of environment? That's something that hasn't been studied as much. For mobile teams, so again, there's work that needs to be done to look at equitable access to post-crisis follow-up. Optimal team roles, this is a question that comes up often. What's the ideal composition for a crisis, mobile crisis service? The impact of involuntary versus voluntary treatment on outcomes, and then also clinical best practices and pathways for presentations and populations. In more facility type settings, there's a lot of work that still needs to be done on how these services actually reduce suicides and overdose deaths, different models, stabilization versus residential versus respite, locked versus unlocked, what's the optimal length of stay, questions like that. And then also, what are roles for peers? What are optimal practices for short-term medications? Really important questions. And then finally, for post-crisis follow-up and linkage to care, which I think is so important for our actual outcomes, how do we think about reutilization risk factors? What are benefits of peer navigators, telehealth, and access to care post-crisis? And then also, what are clinical standards for post-crisis follow-up? So all of these really big questions, a lot of questions that need further development with more rigorous evaluation and research. And then in the section below here in gray, you see there are also a lot of cross-cutting topics. Within each of these boxes, we could ask questions about disparities in equity, about workforce, about roles for peers, rural versus urban, opportunities for technology. The impact of COVID, of course, has affected everything. High utilizers in systems, special populations, client satisfaction, involuntary versus voluntary treatment, and then also the impact of specific policies on how care is delivered in these settings. So a lot of questions. Thank you, David, for the nod for 1 minute. So we can go to the next slide. And so there's a lot of strategies to advance crisis services research, and this is what we're going to be rolling out with Data Corner. We're going to want to talk about opportunities like developing a research agenda, how best to advocate, how to identify strategies to engage partners and both the implementation and also academic side, sharing best practices for research and obtaining data and linkages, aligning quality improvement with metrics and benchmarks, using big data, and then also promoting research opportunities. So on to the next slide here. Every second Wednesday of the month, you're going to see a Data Corner. A different featured presentation is going to be part of this each time. And we're also going to include these Data Corner bites. And so we're going to give updates on recent publications. I've listed a couple here, and these will be posted online. And then also research funding updates so that academics who are involved can find opportunities for grant funding, including, really importantly, the NIMH just put out a notice of special interest that they're prioritizing research for research opportunities in crisis services. And this is a big deal for us to continue to expand the evidence base here. So really appreciate the opportunity and lots more to come.
Looking forward to it. Next slide. Okay, if you haven't done it already, remember we've got this survey going on. We've also got a lot of tools. I know some of you are nosing around our website. Please use some of the tools. You know, the crisis calculator, which Paul is so excited about and makes us all so excited about. Our speaker today, Tonja, please go see her film. It'd be really helpful. And I just want to remind you, coming up, we've got Vicki Wachino. We're in a moment, meeting it with Medicaid. Looking forward to that next week. And I will see you all then. Have a wonderful weekend. And thank you for joining us today. Bye-bye.